Good morning, my name is Susan Gleason. I am a transplant social worker from the University of Utah, and today we'll be talking about healthcare literacy, which is a subject that's been around for a long time, but mostly addressed from the perspective of the system rather than patients. So we really want to talk to you about how you feel about it. So healthcare literacy impacts nearly 1 in 3 people living in the US, meaning they have some problem, or I'm going to lean heavily on the system having some problem that affects their understanding of what's going on to them. It can hit any population segment regardless of age, race, education, or income. So we now well know that even doctors, when they become patients, sometimes have a hard time understanding their health problems and the information given to them. So it doesn't matter who you are, you can have a problem with that. It costs the healthcare system as much as $58 billion a year. And as we go on and talk, what I'm going to say to you is that I believe that cost is so high because we are addressing it on one end, which is with patients, and not so much with the medical system in changes we could make that would be less costly. It cannot be diagnosed by medical technology, and it's not visible to the eye. So the definition is the capacity to obtain, process, and understand basic healthcare information, and then to also understand the services you're offered. But what if just that, the definition, becomes a problem? What does it mean? Well, do I know enough to find information, to kind of organize information, and can I then understand what's going on with my own health system? It's dependent on individual and systemic factors, okay? So I'm going to again say I lean heavily on the system, making sure that it provides the right kind of help and makes the changes. Communication skills of patient and professional are very important. And usually right here, I kind of come up and I say to you guys, you know what? My favorite universal hand signal is this. Because unless you're able to do that, as you're talking to your healthcare professional and say, stop, I really don't understand, you need to speak slower, I don't understand the words you're using, you are going to have a problem. And it's very difficult for people to do. We all have kind of inner things that say, well, if I do that, will they think I'm stupid? Or will they think less of me? And this should not be the process. And I think that social workers such as Connie and myself are working on this all the time with the medical professionals and patients. You have to have knowledge of a patient and the professional of healthcare topics. So for instance, I think that Gordon can tell you, he's a healthcare professional to a certain extent. He speaks to lots of patients, but he can tell a patient, I had a transplant, and this is what I went through. He can't tell a patient that's what you went through, and he can't give a patient actual medical advice. So there are people in the medical system that shouldn't be doing that either. I've had people call me on the phone and say, well, you know, my labs, da-da-da-da. I respond to them by saying, I'm going to get you to the right person immediately. But I can't really give you medical advice. Who wants their social worker giving them medical advice? You know what I mean? The third issue is, I think, the biggest issue, which is culture. And we're certainly going to look at that. Another issue is there's a lot of demand on the healthcare and public health systems. So because there's so much demand and they're being pulled in so many different ways to provide services, they often, I think, fall short of being able to give you the information you need. And there are certain demands on the situation and its context, too. So, for instance, you guys are a very special group. You're a transplant group. And that is a special situation. And people need to respond to you based on that situation, just not any normal medical situation. And it's all the way across the board. Medical information all the way to social and emotional information. We need to make sure we're responding to you based that way. So there are certain things that some systems pay for, or all systems try to provide for any of the following areas. If you have a learning disability, a hearing problem, speech problem, writing, reading, language barriers, Your system, the university, the VA, whatever system you're in, should provide some help for you in those areas. But even as we talk about that, you can see, well, that may help you with that, but you still have to say, what is the provider doing to understand these things? Does the provider understand they need to get me this help and how quickly they need to get me this help? So at the university, we provide the following. You can have language translation. We have people who come in and sign for the deaf. We have pocket talkers for people you know who have some hearing problem. It will magnify the sound of that person talking to you. We have note takers. So if you're a university patient and you say, I don't understand what's going on, this department can actually be called and send someone to take notes for you. And the buddy group, which is what you're part of here, has strong feelings about helping you complete forms. We don't feel that unless a person totally cannot do it, that we should complete forms for people. But we do believe we should be able to stand by, help you fill out a form, so in the end, you're functionally able to say, I did this, and I can do the next one. So you have a right to ask for help, and at the university, you can contact your hospital's relations department and ask for help. You can tell your provider you don't understand. You can contact your social worker and say, help me, I need to understand what's going on. You can bring a buddy or a friend, and you guys fortunately have that built in with the requirement for caregivers. And you can ask again and again till it's clear. And I don't care if you have a provider that acts like they're irritated with that. That's not their right. It's your right to make sure that you can leave a room and you know what's going on with you. So we feel really strongly about that, and social workers specifically want to support you in doing that in every way. So healthcare literacy is dependent on culture a lot, and it affects how people communicate and understand health information, how people think and feel about health issues, when and from whom they seek care, and how they respond to the need for lifestyle changes and treatment plan. So with that, I'd kind of like to ask you guys now to be involved, because maybe you're aware of some cultures that look at healthcare differently than, say, your own. Do you know of any? So if you were a Christian Scientist, would you view healthcare different than, say, the average person in this room? How might you view that different? Do you know? I think you do.
Yes, because they have a lot of faith and they use different ways of dealing with it rather than all of the doctors.
Yeah.
And they have a lot of faith in for healing rather than and their home remedies and
Yeah. Does anybody here know what their stance is on blood transfusions?
Yeah.
No blood transfusions,
Yeah.
right? And what their view is on sedation and medicines. So it can be very difficult, and you could have a patient in the hospital with this culture, but be told all you can do is provide a bed for them and basic, maybe, nursing cares, and everything else you can't provide, no matter how strongly you feel. What about,
I think there are some cultures where women would be very uncomfortable having male medical staff treating them. They would want other women treating them.
yes, Mary indicated that she thinks there's some cultures that are not as comfortable with, females are not as comfortable with having male medical staff. And I've actually been in situations here, Mary, where it's been in the reverse also. That men have said to us, we'd rather have a male nurse than a female. I think it's more prominent among women, but that's true. And is there anybody here who knows, say, what the Jehovah's Witness stance is?
They don't have, Jehovah's Witness, they don't do blood transplants. They don't transfusions and,
That's right. I do think that they have indicated that transplant is okay. I'm not sure how you do that if there's no blood transfusion. And the Christian Scientists have said no to transplant, totally. Okay?
It's mind over matter.
Yes, exactly. So it's really important. There's also in the Hindu religion, Hindu diabetics will not use synthetic insulins, only insulins made from animals. So it's important that we know these things, and it's important that the medical provider knows these things before they just kind of go barreling in. Because does anybody in this room agree with me that sometimes you feel like you're on a conveyor belt? The doctor comes in and says, you're going to do this, and this is da-da-da-da. And he doesn't really say, do you want to do this? He just says, are you going to do this? So I think this is part of going back and looking at the system's responsibility and saying, that a lot of money could be saved that they think they're spending by training doctors and nurses up front better in terms of how they communicate. So also, when and from whom some of these cultures seek care is really important. So obviously, when we're talking about the Christian Scientists, they would rather have a Christian Scientist provider. They don't want just any doctor. Hey, Craig?
Yes, I'm going on cultures and traditions. I feel that I feel in my heart there should be a doctor and patient relationship. I have a great relationship with Dr. Stellick. Awesome relationship. He knows how to speak to me. I know how to respond to his way of speaking. Because I've done a lot of research on this stuff. They say, well, he needs to take this BID. Means what? Bi-daily, twice daily. Or, some people won't know what that meant. But he kind of breaks it down. He has real good bedside manner. He does. He doesn't look at me as patient number 4. He looks at me as Craig, Amy, not Mrs. Nielsen. I mean, yes, you have to be a professional way, but also have that relationship with them because, number one, you're going to be with them for a while. And that's how I look at it. That's why I get into talking to vet patients about LVADs and transplant because they want to hear what they need to hear. Not what they want to hear, but what they need to hear.
Exactly.
And the thing is, like yesterday I went up and saw one of the patients up there and nobody talked to him about LVAD transplant. So I happened to be up there and I introduced myself and spoke to him and prayed over him. And he had a little insight of what's going to happen. So I think relationship between the medical staff and the patient is a must. And the bedside manners has to be a must.
I almost believe that once you get to this level, I hope that it's better for everyone than, say, when you start down with your general practitioner or maybe internal medicine doctor. But does everyone here have the same experience with their transplant physicians?
The doctor that treated me for the lung disease before I got transplanted still stops in to say hi to me when I'm going in to see the transplant coordination team. And I mean, we have such a strong bond. It's unbelievable. I don't think I've ever had a doctor who was not my doctor anymore, but still that caring and involved in my case.
That's amazing.
Yeah.
It really is. And so what Mary's telling us is she, even post seeing a doctor, not seeing this doctor anymore, really has a good relationship with this physician. And she feels like he reaches out to her, not her to him, to maintain this relationship. And I think you're saying the same thing, Craig, that you're experiencing something very good. The last thing is, under culture, is how a person responds to the need for lifestyle changes and treatment plans. So if you have a different culture, adjusting to some of the changes, like a VANT, or some requirements around a treatment plan, can be very difficult. So an example, Gordon's a shining star, but in liver we have many patients who have substance issues, alcohol and drug issues. And they have to adjust to changing those habits. They can't receive a transplant and not change those habits. So a lot of people end up after transplant having to make some fairly significant adjustments. From a patient's point of view, though, not everyone, but we think a lot of patients say things to themselves like, I don't know how to read, and this feels like being blind, ignorant, not able to understand or ask. When you come into transplant, and Connie and I do evaluations, that's usually a question on our evaluation just between us and the patient. And then we try to let the medical team know, you need to find other ways to give this patient information and try to help them feel like this is not a problem, really. So that's, again, really a lot of responsibility on the caregiver, and I would expect that. They may feel embarrassed to tell the doctor you can't understand, which is kind of where I started with this saying that, my universal hand signal. This is a problem that we hope we can affect some change in. I actually am a provider, but I'm also a patient. And I recently had to say to my doctor, wait a minute, you told me to get this physical therapy, but I don't understand this word for the type, So you really have to kind of say, what happens to me is more important than how I think they feel about me, and you really have to solicit more and more information till you understand. Now, when you're waiting for transplant, you're pretty sick a lot, aren't you, Craig? And then you don't have the strength or emotional ability to deal with that. And so that often falls to the caregiver, thus increasing the the workload for the caregiver, because the caregiver is trying to take care of everything else too. But since I've been in transplant, I've never actually met a caregiver who said they were committed, who didn't work really hard at saying to the physicians, we don't understand this. And because we have to take care of this person, we need to understand it.
Well, they kind of make us feel embarrassed because of the fact that some docs can make me feel intimidated because the way their persona comes in, they come in and it's just like, wow, when they first diagnosed me with idiodilated cardiomyopathy, well, what in the world is that? Okay, why didn't you just tell me I have congestive heart failure?
Exactly.
So it makes us feel embarrassed and feels like they intimidate us a little bit because they have that knowledge. Excuse me they have to talk to me in kindergarten language. That's fine. I want to understand what's going on with me.
Exactly.
For you to tell me all this medical terms, fine. That's fine. That's what you learn. I grant you that. But I'm not in medical school.
Yeah, and there's not, I think, enough direction pointed at the medical system to say, come on, you need to do this. We know you went to medical school. We know you're real smart. That's why we go to you, okay? But we really want to understand at our level what you're saying. And so I can tell you that every Monday night, and Connie has to do this at times, I go to a meeting which is called selection meeting. And in that meeting, everybody talks about whether a person is appropriate for transplant. And by the time the doctors get finished, I'm like shaking my head going, well, I think they're socially just fine. But what did you say? So when you say it, it's kind of embarrassing. It's embarrassing all the way up to my level, I'll tell you, it's the truth. So we can ask them, slow down. And what you just said, please use plain, non-medical language. If you have to, show me or draw me a picture. And last time I actually brought handouts, which I didn't bring today, which I have available, which are nothing but pictures of organs with everything on there. And you can actually take that picture into your physician and say, show me. Repeat important information and use demonstrations. Now, I think we're pretty good here at using demonstrations at the U, but I don't know for sure. How are they at the VA?
Pretty good.
Yeah. So I think that they might have that down in terms of.
They do here at the U, they do, not at the VA. Like Seligman,
Yeah.
he'll diagram a picture of what happened to my heart.
Mhm.
And he'll show exactly what the heart does, or what the VAD pump does with the flow. He'll exactly do that. That's what I liked about him.
So Dr. Stelly.
Seligman,
So,
the
yeah.
transplant doctor.
Yeah.
Yeah. So
Good-
anytime
good.
you have a physician that does that, that's really great. It's helpful. Don't be shy. Ask for clear instructions. Repeat what you're hearing. Demonstrate from the provider. Be specific with your questions. Obtain backup and written visual instructions. Let your provider know how you prefer to receive the information, written, orally, or visually.
I was misdiagnosed for 3 years before I found the university doctors here who got me a correct diagnosis. But one of the things that I learned the hard way is if you have a doctor who appears to feel threatened or unwilling by your questions, time to find another doctor.
Yes, exactly. So one of the things that has happened to me a lot, and Connie's gone, so I don't know if it happens to her, but all around with the team. And then the surgeon, the transplant surgeon comes in and he goes, da-da-da-da-da-da-da-da-da. And then they leave the room. The herd, I call them, the traveling herd. So they all leave the room. And I say to the patient and the caregiver, what did they just say to you? Because I'm not sure I understood all of it. And at that point, I have many, many patients and caregivers say, well, we really understood this piece, but not the whole piece. And so that, I think that causes a certain amount of discomfort. Now, when you're at an ICU level, often you can get excellent information just from your ICU nurse. But I always tell a patient or a family member, if they didn't understand, I'm going to go out and find out exactly what this person means.
Once they got through in the room, I used to follow them out and listen to them in the hall.
I do that too.
Yes.
I do that too.
And that's really an excellent
I
plan.
would follow them out in the hall and listen to them, see what they said, yeah. Because then after they walk out the room, then they speak in layman's terms that you can understand.
Yeah. You don't know why they're talking to themselves that way, but they come in the room and they're impressing,
I
huh?
find out additional information out there.
Exactly.
So I really don't mean to totally beat up our systems. We have wonderful systems, don't we, Connie? We really do have wonderful systems. But there's years and years of things being done and people saying, well, that's just the way it's been done. And so these changes that seem so simple to Connie and I are actually not so simple to the providers. So, and this is just, I know that pharmacists are usually pretty good. But I'm going to hear from Mary. Show me how many pills you would take in a day. So they give you, when you leave after transplant, don't you get a grocery bag full of medicine?
Grocery cart.
2 grocery bags.
Okay, and then they're saying, you know, and they're standing there and probably very carefully saying to you, now you take this one this way, this one this way, that one that way, and they're doing their best at helping you understand. But come on, a grocery bag, 2 grocery bags.
She gave me the big pill box with all 4 things a day, 7 days for the week, and all of the 2 bags full of pills. And she said, okay, now fill this up like you would for a week. Well, first of all, I was still very ill. And second of all, I was extremely exhausted. And third, I was a little pissed off. It's a very vivid memory of just wanting to throw them across the room.
And evidently Larry caught on to that too.
It was intimidating there, but you really kind of learn once you get home the first time you do it.
said, let me do it for you this time, and then you can do it when you're feeling better at home.
Yeah, I was gonna add to that. Maybe the provider should do it for you first. They should fill that pill box first, so then all you have to do is do a go by like every week.
Yeah.
Yeah.
Yeah, that'd probably be a
The-
suggestion.
The pill, what do you call it, schematic with all the colored pills and everything else really helped a lot the first
Okay.
couple of times.
Okay.
Because they would put down how many of each and what it was called, and what it was for, and the color of the pill and all that. That was very helpful.
Okay. We ended up putting because I couldn't open those.
Adult caps, you need a
I
kitty
couldn't open
cap.
them.
Yeah.
So we got all kid proof, and we ended up with a permanent marker putting what it was on top. So that still helps too. Yeah.
Wasn't that part of the educating the patient and the caregiver? When they say, well, we're gonna educate you on the medicine before you get discharged?
They
Yes.
do.
They do.
But I mean,
Well,
it's
no, they
for what,
educate
like
you, but they don't do
20
this
minutes.
hands-on stuff. They say, you know, this is how you do this, how many tablets you take a day, and all that stuff. They just educate you what type of medicine you're gonna be on.
So do you know where I've heard maybe the most good information about medicines, how to pack them, what to do with them when you travel, what is in this group?
Okay.
Because you're right to some extent, but mostly Mary is too. It's just kind of overwhelming and you're still kind of sick. Your caregiver's pretty tired after all this time. So what I've heard is, number one, we do medicines once a quarter. And the same pharmacist who may talk to you here at the university comes and teaches that. And I have people, I had a heart patient who came for a year after and still did all the education stuff just to make sure he was leaving state and it was going to be firmly implanted. But what happens is when that person comes to do medications, they take a little more time. They're a little more willing to answer questions. And the best part is that there's people in this group saying, oh, well, I don't know if you know this, but this is how I pack mine, or this is when I do it, or this is what I do when I travel. And that is some of the best information you're going to get is right here from your friends that are all doing it. So anyway, show me. So the last thing is that, like I said, I have some handouts, and I don't have them today. I'll be glad to bring them next week, but I think that especially for patients that are looking towards a procedure, and you may say, Craig or Gordon, you might say, well, I'd like to have the liver one just to show people and say, you know, this is your liver and these are the parts. I'll be glad to provide those for you. But we have one, and very interestingly enough, we have heart patients in this group, VAD, livers, lungs, and we really don't have kidneys because the time they stay in the hospital and the time they stay is so short. However, we do have the kidney and try to tell kidney if in fact you have somebody you feel is struggling with getting this information, even though you only do a half a day's training or a day's training, if they're local, send them out. Let them spend time with us. And I'm not sure that's happened yet, but we're hopefully thinking it might. So you're not alone. But there's lots of people that resist coming to this group, and they do feel alone. Medical studies indicate most people feel uncomfortable in a healthcare setting. So get the most out of your doctor's visit and improve your healthcare literacy. Or, as I put it, improve the degree to which you might understand what they're saying.
Yeah.
He took out my joke, and I really loved my joke. But I do have one that shows a doctor talking to a patient, and he says, this is your new pacemaker. But it also comes with apps for heart and lung. Thanks so much, you guys. Questions?
Actually, more like a comment as far as that last slide goes. You can ask your doctor for what's called an op note and to show you x-rays, because I want to see what this pump looks like in the chest. So they're working on that for me. But the op note is basically what they did when you were in surgery. And of course, it's not in layman terms, but I mean, you can look up some of that stuff or have somebody explain it to you. the whole surgical note, they have to post that for you.
Yeah. You actually have the right to all your medical records, and you can ask that a medical person stand by and review them with you.
Yeah.
I just recently asked for all my medical records from when I was in Dallas and here since I've been here. Everything. See, copies of CDs of my echo, everything.
Yeah.
So,
I think it's very nice to have, just based on the fact that you want to know what's going on with you, but also, you never know what's going to happen in the future. And it's
Exactly.
nice information for a family member to be able to maybe provide a new medical
Well,
system.
what if you have to fill out some insurance information and Connie Joe's not around?
Right.
This is what they did to me.
Right.
This is, you know,
Exactly.
what they say I'm gonna be doing in the future, or, you know.
Or you're in a different state.
Information.
Right.
Instead of calling and having them look it up on the computer, you have it right there with
I
you.
got it memorized.
Other questions or comments? We love them.
Susan, it seems to me like one of the presentations we had a while back talked about the way that people handle medical information, and there were like two different styles, and I can't remember what they called them, but there was the one group that wanted to know all the nitty-gritty details, give me all the information, I want to understand everything about it. And there was the other group that was just overwhelmed by all of that information, and it was just, give me the bottom line.
Yeah, exactly.
And I can't remember what they were called, but
And-
that was really
Avoidant
interesting.
and vigilant.
Avoidant and vigilant. And Connie Jo does that
Preparing for
presentation.
surgery.
Yeah, preparing for surgery. So it's true, and it's very helpful to let your doctor know which kind of person you actually are. But Connie, remind me, have we found that we're almost 50-50 caregiver and patient, or not quite? No?
No, a
Okay.
lot of times the caregiver is the same as the patient, and sometimes they're opposites, but a lot of times they're exactly the same.
Okay, so,
Just depends on the group, but we've had quite a variety.
As me, as being a patient, when I was first diagnosed with this, I took it to heart, and this is me, because I'm always a person that's always informative and always want to get information. I'm a very detailed person. It's easier if a person can go online or on a computer now, because it's easier than going to a Britannica and find out and do research on what you're diagnosed with. And I knew I was going to eventually get an LVAD, so I did research on that. So that kind of helped me in advance what's going to happen, what type of health care I'm going to get. Same as a transplant. You know, when someone told me what's the bridge to transplant, I didn't know what that meant. So I go online, look it up, and I'm a person that always like to research things all the time. And if a person can do that, that will eliminate a lot of the stress of not knowing or being illiterate about the healthcare. You know, because in honesty, it's your responsibility to yourself to know what your body consists of and what it needs.
Yeah.
So
exactly.
when I was first diagnosed with that, that's the first thing I did. I researched it.
Now, if you're in the hospital already, does everyone know, at least at the university, we have a library where you can access and use the computer?
Yeah.
Do you have that too, Connie?
They have to go down to the library to do
Yeah.
it. We don't have Wi-Fi in our hospital, but you can go down to the library.
Yeah.
I mean, it just makes it a lot. It made it easier on me because I knew what was going to happen, what was going to consist of.
Yeah.
I mean, it didn't particularly go the way it did, but you know the general knowledge of it.
I actually had my, because it was like a conveyor belt. If I hadn't known myself about the LVAD
Mhm.
or the Dick Cheney, they wouldn't have, they didn't actually, we used to call it Dick Cheney. The doctors were just pretty much going over my head with
Right,
people. So
right.
if I hadn't known myself,
Right.
and was able to request it myself, they would have just kept talking to each other. You know, I wouldn't have gotten the information that I already had I not.
Before I end today, I'd like to ask you guys one question. And that question is, including this group, how do you think we can improve or try to make projects to improve this problem?
Probably more literature and more
Communication.
layman's term, exactly.
Communication.
Training, layman's terms.
Communication, more
You know, even
training.
if you had to bring somebody from the outside to almost interpret what the doctors were saying,
Mhm.
or leave them in the room after the doctors left, which I had a lot of in Atlanta, I had a lot of interns that would stay back or come in when the doctors weren't in yet and kind of talk to me on layman's terms.
That's very helpful.
Yeah, so, you know, it is communication and the relationship that you have with the team, basically. Yeah.
Any other questions before we conclude? Thanks so much for coming, you guys.